Hello, everyone, and welcome to today's one-hour webinar, My Pumping Pathway, Standardizing a Personalized Approach to Pumping for Practice and Research with Dr. Paula Meier, PhD, RN. Before we start, I would like to review a few items so you know how to participate in today's event. You've joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. You can submit your text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect them and address them during the Q&A session at the end of Dr. Meier's presentation. Today's webinar will be recorded and made available on Mediela University and Mediela's Education for Lactation Professionals YouTube channel. There is a handout available, so please be sure to download it before the end of the live event. You will find the link in your go-to panel in the handouts or materials section. I would now like to introduce Dr. Paula Meier. Dr. Meier is a professor of pediatrics and nursing at Rush University Medical Center in Chicago. With a career spanning nearly 5 decades, Dr. Meier has made significant contributions to the field of human milk, lactation, and breastfeeding as a practitioner, researcher, and educator, particularly for premature infants and their mothers. Dr. Meier's continuous advocacy, research, and mentorship have left an indelible mark on the lactation field. Her legacy continues to inspire and shape the future of neonatal care. Dr. Meier, take it away.
Thank you. Hello, everyone. And as we get started, I'm going to just say in advance, I'm in Chicago and we are supposed to have thunderstorms in the next hour. So hopefully we'll have good karma and get ourselves through this before the internet goes out. So I'm excited to be able to present this material today because it's new and I think it's also very exciting. As usual, I've listed my disclosures, and all of the ones you see at the top are all different research and demonstration projects, traineeships for students. And my only funding and consultation for my work is with Mediela. So the goal today is to introduce my pumping pathways as an instrument for research and for practice. And we have 4 specific objectives. So first, we're going to look at the evidence and background information that really tell us why we need my pumping pathways. Second, we're going to look at the pathways themselves to the extent we can in a presentation, including the QR links to videos and education sheets in the Provide Compendium. We're going to look at opportunities to integrate the pathways into research and QI initiatives that are focused on improving mother's own milk volume as an outcome variable. And finally, we'll discuss the use of the pumping pathways as a potential competency for lactation care providers. So I'm going to spend a lot of time talking about the pathways as we go through, but I don't want to just talk about them and not have you see what they are. So right now, the pathways exist as paper forms. We have a lot of plans for how they will become electronic, user-friendly with apps, but I want to show you what they look like now. So my first pumping pathway is intended to be completed during the maternity hospitalization for breast pump dependent mothers with babies in the NICU. This particular pumping pathway guides the mother through the best pumping practices up until she achieves secretory activation. My second pumping pathway focuses on the whole coming to volume, or as we change from the hormonal control of lactation into what we would call the autocrine and paracrine control of lactation. So what this instrument, or this paired instrument, does is really take the science of early lactation physiology and biology between the mother and the healthy infant and put it into best pumping practices for the dyad when the mother is breast pump dependent. So that's just a little sneak peek, but now I want to go through why do we want something like this. So let's just quick look at some of this evidence. So we always start with the fact that high dose mother's own milk right now is valued. We know that there's a dose dependent effect on the amount of mother's milk through to NICU discharge on the risk of potentially preventable morbidities as well as their costs. And I reference here our research, the Love Mom cohort, for which I was PI, and we produced all these different papers on how there was a direct dose-dependent effect on all of these different complications, as well as their costs. So this, as well as other papers, have informed the need to prioritize mother's own milk volume as a NICU outcome all the way through NICU discharge. So what do we know about rates in this population? What we know is that mothers initiate milk provision for babies when they are born prematurely at very high rates. And many of the actual NICUs or quality improvement networks actually show higher rates in the breast pump dependent population than in mothers with healthy babies. Also, most of the studies at this point show there's very little, if any, disparity with respect to race, ethnicity, or income. Mothers get the message about how important it is and they start pumping. However, at NICU discharge, we see lower rates, despite the fact that we know from our own work, mothers have a goal to continue milk provision, and we see a Black, non-Black disparity. The primary reason that mothers report is that they run out of milk or they don't have enough milk for their babies. At the same time, we look back, okay, well, what tells us, what's the best practice that tells us how to get to discharge? And right now, it's really our work by Dr. Hoban that shows that the primary predictor of receiving mother's own milk at NICU discharge, and this was with 415 mothers, so it wasn't a small sample, was whether the mothers achieved coming to volume, which is equal to or greater than 500 milliliters by postpartum day 14. This was a stronger predictor than race, than income, was coming to volume. So what we want to do is think, okay, well, if this is the primary predictor, how do we get mothers from the time they give birth all the way through this 14 days with an adequate milk volume? So the other piece of evidence is that the pump should mimic the healthy infant to the extent possible. And when we think about the infant, it's not just the infant, it's the dyad. So it's a critical window during which the physiology of the mammary gland and the biology of the infant work in harmony. And what we need to be able to do is to take this into breast pump technology. So as you can see over here in the corner, we really do not have a simple to use tool that standardizes personal breast pump use for NICU moms. So this is the evidence. Let's look at the reality. And I know this is going to ring a lot of bells with people in the audience. So there is a strong science of what we call milk removal. How is milk removed from the breast? And that's really poorly understood, especially among people that aren't just immersed in the research in this field, but we know quite a bit about it, and it's not routinely integrated into completeness and competencies and in teaching about breast pump use. I would also add, at least we see these in different things where I have been consulting, is that pumping mothers are often disenfranchised because the breast pumps, the equipment, the supplies are selected based on ideology and cost, rather than whether those breast pumps and supplies promote effective milk removal and efficient milk removal. We see routinely that nurses who are the IBCLCs in the NICU or in the mother-baby unit who are skilled in breast pump teaching are often called to assume routine patient care if census dictates, so they do lactation on the side. With the downsizing of IBCLC staff, oftentimes the mother-baby nurse is left to help the breast pump dependent mother because she's seen as less work than the baby that won't latch to the breast. And again, when assignments are tight and there isn't a baby in the dyad, the baby's in the NICU, the assignment of the NICU mother to a lesser experienced nurse or a float pool nurse or to a nurse who already has a higher nurse-patient ratio is not uncommon because there isn't a baby to take care of. So I'm sorry, the garbage truck is across the street. It will be gone shortly. There it goes. So I put a copy of a paper that I think inspired me along the journey of thinking about helping pumping moms. And it was from 2010, and it was one of my PhD students who's gone on to do a lot of work in this field. And it was her very first paper that chronicled the breastfeeding peer counselors in the Rush NICU. And as you know, these were all mothers of babies who were formerly cared for in the Rush NICU. And her reporting of this was the mother's examples about how they've walked in my shoes, they understand. But the one thing that the mothers said was the most valuable to them was that the peer counselor sat with them from the very beginning of the pumping to the very end of the pumping and told them what was normal. They had helped them adjust the pressures. They told them what feelings they were having were normal, what wasn't abnormal. And the mother said after that, they were no longer afraid to pump. They were no longer uncomfortable to pump. So that has stayed with me all that time about how important it is. We would never just hand a mother a newborn baby and say breastfeed, but we do that with a pump all the time. So I'm going to just spend a second here because there's also this lack of rigor in how we tell mothers to use a breast pump that carries over into research when pumped milk volume is an outcome variable. Now, there are many I could choose, and I'm not criticizing any of these because it's really pretty much the standard. We really know nothing about how mothers were taught to pump. So some of the studies don't even standardize whether the mother is using hand expression, what type of pump she's using, whether she's using simultaneous versus single pumping. And we know that there are studies that show that each one of these things that are not controlled are associated with milk volume in other outcome studies. There's no detail provided to tell us for sure that the effectiveness and the efficiency of milk removal, such as making certain the breast shields are sized the right way, the pumping pressures are appropriate, that the mothers are taught to use double versus single pumping. None of that is ever explained. And there's no detail about early pumping. And the reason I say this is that we have paper after paper now that is telling us that what happens in terms of pumping behaviors in the very early post-birth period carries over and has an impact into milk volume at 4 weeks, at 6 weeks, and sometimes even at discharge. So this lack of rigor and the need for having an instrument to standardize breast pump use isn't just for practice, it's for research as well. I would add some of the papers that have been published in this field don't even tell us anything about the milk removal. They just say that mothers kept a log about their milk, and we don't have any idea what they did to remove it. But they were then in a randomized trial of an intervention. So people say, well, what does she know about this? We don't think of her as somebody who's an expert in this field. Well, actually, I've been working in this field for quite some time, and longer than most of you would realize when we talked about that 5-decade career. My first NIH grant in 1988 was comparing suck-breathe coordination for breast and bottle feeding when premature babies served as their own controls. So what you see here are just some, fun photos from that period of time. This is the instrument that we use to be able to measure sucking non-invasively. This is how we validated the instrument. This is the laboratory. This is me. And this is a mother with her baby with all that equipment on. So I was interested and had a background in how milk is removed, the difference between non-nutritive and nutritive sucking, how one interferes with breathing and one does not. So this was always my interest in trying to then determine appropriate breast pump usage in mothers who are breast pump dependent. So I want to spend just a second. If you joined me for last time's webinar, you would have heard a little bit about this and saw this diagram. So when we talk about milk removal, what many people don't realize is that milk removal isn't just about getting milk out for the baby, but effective and efficient milk removal, either by the baby or by the pump, assures the baby gets enough milk, and also regulates lactation processes. In other words, the milk must be removed. We call it supply and demand, but it's a much more complicated autocrine and paracrine control that involves a number of mechanisms that when milk is left behind in the breast, then milk synthesis and secretion is downregulated. So I pointed out before why this is so important for mothers of health, well, mothers of pump-dependent mothers, is that when mothers are breastfeeding their own baby, if the baby is healthy and removes milk and everything goes well and there's no interruption, no separation, both of these things happen at the same time. However, a mother of a premature baby, the baby might only need 100 milliliters of milk or 200 milliliters of milk. If that is what the baby is getting as adequate intake, that isn't enough to regulate the mother's lactation processes. So I always have mothers think about feeding the baby as one milk volume target and how much milk you need to make to regulate the lactation as a second milk volume target. So this simple diagram of milk removal, we know, for example, milk removal is characterized by being effective, getting as much of the milk out as possible, being efficient, doing it in a timely manner. So one of the examples for that would be simultaneous versus serial pumping, because when the mother pumps both breasts at the same time, not only does she have a higher prolactin response, but it's quicker for her. So those are just some of the things to think about in terms of effective and efficiency. Comfort is also an important part here, because if pumping isn't comfortable, oftentimes then the mother leaves milk behind because she stops too soon. The pain interferes with oxytocin, it interferes with prolactin. So at the very least, effectiveness and efficiency, and ideally comfort as well. Okay, so we actually have quite a few studies in looking at milk removal in breast pump dependent mothers. We published our first paper on this topic really back in Breastfeeding Medicine in 2008. And this was looking at the effectiveness, efficiency, comfort, and convenience of the Symphony breast pump compared to Medila's old classic pump. So we go all the way back through there, but we have focused on this area because it is a scientific area. And when we look at the fact that milk is probably one of the safest and the most effective strategies for reducing complications in this population, to say we're going to do our thinking about milk removal based on some ideology versus on the evidence is really to disenfranchise mothers. So this is why I've been unapologetic and working in this field, because mothers depend on the pump, just like a healthy mother and baby depend on each other. So what I've done here, I want us to take a minute and think. What we have, if we look at the difference of these two time periods that coincide with the pumping pathways, one is from the time the mother gives birth until she achieves secretory activation. The second half of this is, okay, now we've achieved secretory activation. How do we change milk removal patterns to be able to optimize this particular process? So I'm not going to go through all of these. I've done this in previous webinars, and you certainly can look at them. But we know secretory activation is the upregulation of these different pathways that make milk. But what's so different about secretory activation into coming to volume is that prolactin is released only with suction pressures from the infant to pump and then milk removal. Skin-to-skin holding doesn't do this. Other non-feeding stimuli don't do this. So it's got to be the stimulation of the pump. Then if we look at what is with the infant, and I am going to spend a little bit more time on this because this is what informs the pumping. What we know is that when an infant, during secretory activation, this first 2 to 3 days, the sucking, the rate, the rhythm, and the frequency of feeding is really timed to the fact that there's so little milk in the breast in this very early post-birth period. To accommodate that, what a healthy full-term baby will do is to suck in an irregular rate that's characterized by little frequent bursts of sucking followed by pauses, instead of what we would think of as a healthy full-term baby. That's that two-phase. The baby sucks quickly, the milk ejection comes, and then we see milk transfer. What's different here is that this early sucking doesn't involve swallowing. Okay, so this is a huge difference, and I think it's important to understand. When babies swallow, it takes more time. They have to close the airway, open the airway, and breathe. So a very rapid suck that you see early post-birth like this is because the babies have so little milk. As milk starts to increase during this period of time of secretory activation and coming to volume, what you see is that the babies have to take time to swallow. So that's when you begin to see the two-phase sucking of like a stimulation, the milk flows, and then a slower suck. So what happens then is, how do we take this physiology and put it into the pump? Well, the first of all was the initiation pattern, because it's built on this specific unique sucking pattern of the human infant when there's very little milk available. And then the maintenance pattern mirrors the infant's milk removal. So what I want to do now is to show you this, showing what the baby does and what the breasts do. And this is what we think of if we look at the infant. This is a healthy full-term infant who's just starting to feed. And we see this two-phase sucking, okay? Baby's at the breast. Okay, and we see this very rapid sucking. This is stimulating the milk ejection reflex. And again, because there's very little milk available. So the baby's sucking rapidly, little milk available, he doesn't have to swallow. And then gradually the milk ejection occurs. And what do we see? We see the baby gradually sucking more slowly because the baby has to breathe. Closes the airway and breathes. Okay, so this is what the two-phase pattern in the Symphony pump does. It is exactly what this infant is doing, and that's why it was created, to mirror the healthy infant. Now, this was a photo or a video that my team took. It's not the best quality, but you can see it well. This is a 17-hour-old baby. Okay, this is before the milk is available. This is the characteristic suck. There is a lot of evidence that suggests that this suck, first of all, we know is uniquely human. Other mammals don't do this, only the human does this. So what we do know is that this is thought to have a very important role. It's not just about getting the milk out. This uniquely human sucking rate and rhythm during the very early post-birth period is thought to increase the efficiency of milk removal down the road, because it actually works towards increasing prolactin receptors in the mammary tissue as well as the number of cells. So it's a programming mechanism. So with that background, what I want to do now, I've shown you what happens in that early first 2 weeks. What I want to do now is to go through the pumping pathways. Okay, I showed you this slide, the first and the second pumping pathways. So the first pumping pathway is completed during the maternity hospitalization. The second pumping pathway is completed somewhere between 5 and 8 days. We have a little flexibility here, but if you were doing it for research, you would ideally do it when you have measured the sodium in the milk, you know the mother has achieved secretory activation, and then you do pumping pathway number 2, which is pretty much how we're doing it in our research right now. So where do they fit? They fit right here. So that what we know is what's happening in the breast and the full-term baby now can be accomplished by having the pump work as the baby during these particular periods of time. So this is what we call the personalizing the breast pump use, from birth to the achievement of secretory activation. And then the second pumping pathway is used as the mother moves into that next stage. Now, I'm going to show you photos of them as they exist right now and how we're using them in our practice and research. Is that this one is 4 pages long, and this one is 5 pages long, and there's lots of space for writing personal recommendations. And as we go through, what I want to focus here is that It standardizes the teaching and the process, but allows for the personalization based on the individual mother. So as we look at page 1, and this is the first pumping pathway, what you'll notice are all the QR codes. The QR codes are if you are helping a mother pump for the first time, what you want to do with this is that you are able to then say that all the mother has to do for more information, or if you find you're working with a mother and you really want to zero in on one of these, you can scan the QR code and it pulls up the education sheet or the video in the Provide compendium. The mother can look at it at a later time, or you can go all the way through and decide you don't need to do it that first time through, but if you visit her a second day while she's in the hospital, you might want to do that then. So again, with pumping pathways, this is page 1 of the second pumping pathway. Some of these items are just quick yes, no, because it's not assuming that the mother's doing these things. It's making certain that they're done and documenting that. So for example, pumping at least 5 times daily is a yes or a no. And then number of pumpings last 24 hours. And then personalized recommendations. Is 5 times enough for her? Does she need to pump more? Using a hospital grade breast pump for all, none, or some of the pumpings. Using simultaneous versus double pumping. So some of these, again, are just so you don't forget to go through these as you're doing your teaching, but at the same time, you've documented them. So let's take a closer look at my first pumping pathway. My first pumping pathway is 4 pages, and it's the outside, and then 1, 2, 3. It's actually 3, counting the front page. So we'll go through just a few things that are on it. So the first pumping pathway introduces the mother to the whole idea of pumping. So one here is providing milk for your NICU baby getting started. The mother can screen here, and it goes to this education sheet in the Provide compendium. That now, when I talk about the Provide compendium, if you're not familiar, has at least 5 or 6 pages or education sheets, individual ones on pumping, and then about 20 different video segments. So when we talk about pumping, there are 5, but this is the first one, and it's the overview of getting started. You know, start the pumping as soon as you can. Use a hospital grade electric breast pump. Use the breast pump as often as your health allows. So it's the basic principles. And then another one here, what will I feel? Reviews, so that the criteria is reviews normal sensations that accompany breast pump use. So you can click to this education sheet and again, emphasize to the mother that she will feel cramping in her uterus. She might feel squirting in her breast. She might have extra bleeding from the uterus when she's pumping. So all of those things that you would go through teaching a mother to feel normal, that these things are normal with pumping, are there that you could pull if you want. So a couple of the videos, what we want to show with pumping pathway, again, example here from the video, avoiding pressing the breast shield, which is an important thing.
So you want to hold these just until you're getting vacuum pressure. You don't want to press in too hard. So I'll let you take it over. And the reason for that is in our breast, we have ducts and they're really dispersed throughout the breast. And we know that from people who do ultrasound, but some of the ducts are right below the skin. So if you're pressing in with the shields or even a bra that may have seams or underwire and it's too tight, those ducts can actually be compressed. And we know from those amazing people who do the ultrasound that even a Doppler that's pushed in too far on the ducts, it can be a permanent blockage. Not always, but they've seen that happen. So we don't want that to happen. And I remember when I pumped, I tended to push them in too. Didn't know all this at the time. But so always kind of look down at yourself when you're doing that and really be aware. Just hold it until you get the vacuum occurring. And we don't want to push in too much, just until you get the vacuum pressure. Nice.
Okay, I'm not going to go through all of these because I'm going to show you each one of them, but
So you want
I'm not
to
gonna
hold
do the
these
whole
just
thing.
until you're getting vacuum pressure. You don't want to press it.
Sometimes
too
what I
hard.
have the moms do before they actually start pumping is we look at where is your nipple base. So that means really taking the nipple in your finger and finding the base of it. Because sometimes it just sort of blends in. And you can see how the nipple base is right here. Okay, so we're not pulling in a lot of areola. What does this feel like on this round part of your nipple here? Is that uncomfortable? Is it okay?
It's okay.
What about on this left one? What does that feel like?
It's okay.
Feel okay? In terms of right here, which is the most?
Okay, we're going to move on to a couple of other examples in the Provide Compendium.
Based on some of the research that was done with these patterns, they really looked at what pressure would be the most effective at removing mom's milk most efficiently, but still it would be a comfortable, pain-free pumping. We never want pain.
Right.
Pain leads to damage on our tissue. So they came up with a guideline based on that research, and it's called going to your maximum comfort vacuum pressure. When you put the pump on, no matter which pump you use, what pattern, you want to go slowly up on your pressure to the point where it's starting to be slightly uncomfortable. So some moms say that feels like maybe pulling too much, maybe a bit of a pinch. We want to get to that point again where it's a little uncomfortable, and then we'll go down to the perfect comfort level. Does it feel okay or too much?
Okay.
All right. What about now?
Okay. So I'm going to stop again to just use examples here. It isn't to take you all the way through everything in the Provide Compendium, but simply to show you examples that as you click to the QR codes, what is available for the mothers. So here, if we look at second pumping pathway, again, what you're guiding the mother through here is she's achieved secretory activation. She has small amounts of milk. Now, what's different? What really needs to change? So the first thing is that moms need to understand what is a normal amount of milk. So this is like number 5. So we want to explain to the mother, as you start making more and more milk, what is a normal amount of milk to make? So this is from the Provide Compendium. It actually came from one of our studies that shows the days on day 2 all the way through day 14. And what it shows is that mothers spend a lot of time pumping in the early days to get a very small amount of milk. But what happens is by the time we see secretory activation, we see more milk with less time spent pumping. So this is, I think, an important thing for mothers to understand, that they will see more milk, and this is what we call pumping becoming more efficient. And that's an important thing for them to know, that they're not going to be making just small volumes all the time. Again, another example here is by now mothers may begin to feel the onset of milk ejection. So if you click here, if the mothers notice milk ejection, which is number 6, what we show is a mother can actually see what that looks like in a pump, as opposed to being told what she would feel or what you might expect to see in an infant. What does it look like when you're pumping and you experience the milk ejection? So again, nice feedback for moms if you wanted to share that particular piece of information with them. Again, one of the big differences with going from secretory activation to coming.
Did we get a chance to really talk to you about pumping to empty and what that means?
Is pumping to empty
until they show more?
Until you're really seeing just occasional drops come out. So yes, we always recommend, if a mom's using a hospital grade pump, doing both breasts at the same time, which is always the recommendation for a mom who's pump dependent, that you really want to not pump over 30 minutes. So we usually say 15 is the minimum, but the guide we give you is when your milk is either not spraying, in other words, that let down, the drops aren't fast, but they've really kind of slowed. And again, you feel your breasts, they're nice and soft all over. You feel like you've really emptied pretty well.
We always suggest you go about 1 to 2 minutes past when those drops have slowed. So that's kind of our insurance that you're really getting out that end high milk, and that's where the highest fat and calories are at. So your baby will grow, and that also is a nice trigger for the brain to say, those breasts are really empty. Let's make sure we turn on milk synthesis. In other words, we start really making milk. How empty we are really regulates our milk supply along with how frequently we pump. So a lot of things go into our milk supply. So I'm going to actually hold this one for you.
Okay, so I'm going to actually stop this one because what I want to show you then is in the actual Provide compendium is the duration of the pumping session is individualized to the mother. Okay, so this is the video pumping to empty, because I'm sure all of you who've worked with mothers, if we say to them to pump 10 minutes or we say pump 15 minutes, that will work for some moms, but not everybody. And one of the big differences as you move from the secretory activation, where the mothers are basically on a 15-minute pumping pattern that is meant to mimic the infant that I showed you, now we're going into the fact that we're going to now try to mimic a healthy full-term baby. And we're going to try to have the baby take as much of the available milk as possible. So that's what we call pumping to empty. And it helps the mother to understand, and we individualize what that would be for her. This is one of the really important things that I think differentiate breast pump use from a mom you're teaching in the maternity hospitalization to a mom that you're trying to optimize milk volume as she goes into that second half or that days 5, 6, 7, when you're going to be trying to focus on her making plenty of milk. One other one is, again, looking at areola and elasticity, because we will want to make
How are your nipples feeling now in the circumference?
The right one is good. The left one's still a little bit more pressure.
Yeah, it is pulling in quite a bit. So what I see when I look at you is I see a little bit of the areola being pulled in.
Mm-hmm.
One of the things that we look at with moms is how elastic their nipples are. Some moms have nipples that are so elastic, they just, no matter what size tunnel you give them, they just go way out.
Mm-hmm.
Others moms have very non-elastic nipples, so we're all different.
So the focus here being that we're trying to help the mothers understand that as we move from pumping pathway 1 to pumping pathway 2, we oftentimes need to change the size of the breast shields to accommodate comfort for the mothers, especially if there's been edema in that early pumping. And one of the things that we find, I would say in probably at least 30–40% of the cases, is that mothers may need 2 separate size breast shields for each breast. And that again is something that typically we don't see as much in the first pumping pathway, but we always evaluate it with the second pumping pathway to see if it's changed. And then finally, page 4, I just put an example here. So one of the things I didn't show in the Provide compendium that, because these are somewhat longer videos, is how to teach the mother to do a breast assessment pre and post pumping to make certain that the breasts are empty. There's a lovely video of that in the Provide compendium. But the other thing we want to do as we meet with this mother the second time, so this is really to launch her into the copious milk production, or at least that 500 milliliters, is to be certain she knows red flags. And one of the interesting things when we did a little piloting of this with our quality improvement group, and they say, well, we deal with these as mothers tell them they occur. And I think, that's one thing, but at least we found oftentimes that mothers don't know what's normal and what's not normal. So in here, we have notify the lactation team if the following occurs. So we go through these with our teaching. I personally, I never ever did a counseling with a mother at this point in time that I didn't tell her about mastitis and plugged ducts, what to watch for, because of the numbers of times that we've seen mastitis in our breast pump dependent mothers in the NICU that they don't realize what it is. So, so one of the things we always talk to them about is, could the soreness in my breast be mastitis? Because we want them to understand that they don't just go to the local Instacare place, where they're going to be seen by somebody who doesn't understand the babies in the NICU. They want to let us know so that we can be certain that the mothers are given appropriate antibiotics for a baby who's in the NICU. So the final one is red flags. And as you can see, one of the things in the pathways is we've left plenty of room for comments and recommendations for the individual mother. So I want to move from the pathways themselves. This is a quick overview because it's really hard to get all of the content into this short webinar, but I think that as you have the opportunity to work with these, especially as you become comfortable with their link to the QR codes in the Provide Compendium, you're going to find that there are probably many things that you already cover, but probably not everything, or you may cover them in a different time or a different approach. But what we have found is that it's a wonderful way to document what you are doing. But let me move on now into recognizing opportunities to integrate these. So I want to just share with you that we're in the process right now. I say we, I and my colleagues at University of Florida, so Leslie Parker and her students. And then we also have a couple of other people, which I'll go through, that are working on evaluations of the pumping pathways so that we are able to put them into subsequent research. And I know that Medila's intent is to put them into a number of different applications, which I'll go through in a moment, so they're available in the clinical space as well. But if we look at the evaluations, right now we have different outcomes. So we want to look at what do the mothers think about these. Do the mothers think they're useful? Do they gain knowledge and skill? Do they gain confidence? Do they think they're about the right amount of time? Are they too long? Secondly, we want to look at the lactation care provider. So this could be mostly we're looking at IBCLCs, but there are also some institutions where that role is taken over by a NICU nurse or an advanced practice nurse in this field. So what we're looking at is, do the lactation care providers think that it's covering the right content? Is it useful for guiding their sessions? Do they find that the audio visuals are worthwhile? And is it useful for documenting what they've done? At the same time, we have a larger study going on, which is a case control study where we're using the pumping pathways in one cohort of mothers and not using them in the other cohort of mothers. They're actually two separate but very closely related studies. This is at University of Florida. And for one group, we have standardized the pumpings using the pumping pathways, and the other group we have not. So we're going to be matching the mothers as a case control, and we're going to look at lactation outcomes. What is the timing for the achievement of secretory activation, and a yes, no as to whether they achieve it. Achievement, yes, no of coming to volume. Are the babies still receiving mother's own milk at NICU discharge? And we want to look at the proportion of feeds that are mother's own milk versus donor human milk and formula, because what these are going to lead to is what you see here, which are the economic outcomes. So we're looking at the fact that probably this is going to be more time consuming than is standard in many hospitals right now. Not all, but some. And I would get myself off the topic here one moment to say they look a lot more time consuming than they actually are to complete. Because when I went down to University of Florida to teach the team there how to use these, what happened is they became long because of the mother's investment and interest. So I would be done with the content in terms of what I was teaching the mothers, and they would say, oh, well, this is so, can you tell me about this? So it was really an engagement on the part of the mothers that took a little longer to complete. So, but there is like an upward learning curve. You need to become familiar with the Provide Compendium so you know what you're going to offer and not offer. And you get very good at individualizing to the mothers. And again, those of you who are experienced, this will come a lot more naturally to you than those of you who are starting out in this field. So we think there may or may not be some added costs to complete. We don't know, but we think that there's probably a cost effectiveness based on the fact that we're going to have improved lactation outcomes in terms of saving on donor milk, receiving mother's own milk at NICU discharge. But right now, those are all underway. I will say, I'm going to move into this one in a little more detail. This actually is done. We have collected all the data. We've studied the mothers pre and post in very structured questionnaires about the utility, about the knowledge gained, about what they thought was the most valuable thing that they learned. Was it about the right amount of time? So those data are done, and we're in the process of analyzing those. So this was actually the very first pilot testing, and I showed this to a team of quality improvement users once before. This was when we started the pumping pathways as the very first time. So I went to University of Florida, taught the team there how to use them, and we did this simple after teaching with the individual mothers. So it was a way of just assuming, is it too long? Do the mothers think that this is helpful for them? So this was the doctor, or not doctor yet, but almost, Angela Monk, who's a PhD candidate, is taking this on as her PhD. And she's the one that has completed the 15 or the 52 formal evaluations. And it's not this tool. This is the beginning one. And I'm showing it, and you have it in your handouts, because this will be a great way if you want to just start with using these to gain some feedback on the mother's perceptions. This is a very straightforward, simple tool, as opposed to the ones we use for the research, which are quite a bit more extensive. So then, Jessica Gomez, who's a nurse practitioner, PhD, just got funding to look at the pumping pathways in a 2-phase trial at the University of Texas. And the way this is going to work, we are studying here the provider perceptions of using the tool. So what we're going to start with, hopefully her lactation people aren't watching this, because this will make it a little difficult. The lactation care providers, and most are IBCLCs, although I think there's 1 or 2 NICU nurses that will be doing this, will be observed during a standard teaching, not using the pathways. They don't know anything about the pathways. And they're going to observe 2 separate one-on-one sessions with mothers. The observer is going to use the pathways to determine which of the content in the pathways, which is all evidence-based, is covered by the practitioner. The session will be timed, and then afterwards, the lactation consultants will be interviewed about, was this a typical teaching for you? Do you feel this mother had special needs that you needed to spend more time on? So in other words, to understand how they structured that teaching before the tool. Then we will have training on the use of the tools and the QR codes, and then we'll do the very same thing afterwards. And the lactation care providers will look at 3 separate one-on-one sessions with mothers to denote which sessions are covered, which components are covered in the session. The session will be timed. And again, we will have the interviews. And the interviews with the peer counselor, or with the lactation care providers, are going to focus on, were the audio visuals helpful for you? Were they specific to NICU mothers, which is what we think at least our mothers have always asked for, something specific to NICU. So finally, to discuss the idea of competency. So I have been working with a quality improvement consortium on people that are kind of like beta testing these. So they're not a part of the research. They're looking at them in their own practices. And these are 15 different institutions throughout the United States. And so we've met 3 different times now, and we'll continue meeting. And what we've heard is that the practitioners feel that this will improve and standardize the documentation of what they're already doing. So it's a great documentation tool. People think there will be utility, especially when you have to work with mothers from a distance. So if you're doing distance teaching and mothers at another hospital, that you've got a structure to be able to do that along with the QR codes. There is a lot of interest to integrate these into the electronic medical records. There's a lot of interest in making an electronic app available for the mothers so that this can be a combination of the mothers sending the information to the app or the mothers sending information to the EMR. So this will be something I know that Medela will be working on as they've taken ownership of these. We know there's a need to translate into other languages. But the final one that I wanted to share with you, which kind of surprised us from the beginning, was in this group, there was uniform agreement that the ideal use for these was for competency training and continuing education for lactation care providers, that this should now become the competency if you're going to be, if you will, almost competent or certified in helping breast pump dependent mothers using an evidence-based practice, that this instrument, the two-part instrument, is really the ideal way to do that. So these are going to be things that Medela is going to take on. I know Jess was going to put a few items in the chat on when they were going to become available and in what capacity. And I know that they want feedback from all of you in terms of what you would recommend in the way of application for these. But just in summary, as far as we can tell, this is really the first tool to leverage the evidence on the biology of early lactation and mother's own milk removal with healthy dyads and put it into a set of practices that optimize milk volume in breast pump dependent mothers of NICU. So it's taking what we know about the breast and the baby as a dyad and putting it into how the mother uses her pump as a baby. So the QR codes link to the videos and education sheets in the Provide Compendium, and they offer NICU-specific audiovisual teaching examples. I've talked about the Provide Compendium throughout, and I think many of you have actually heard when I've done presentations on this. I have put the web linkage for that again throughout the presentation. This set of materials is available free of charge. So you can go onto that website, you can download if you find, there are certain education sheets that you want to download that you use all the time with mothers in your NICU, like that getting started with pumping or what will I feel when I pump. If that's something you think you always want to have, they can be downloaded, printed, they're free of charge, and you can use them just like they are. They're from the foundation. The same with the videos. But the nice part is they can be linked with QR. So as I mentioned, the studies are underway that are examining the feasibility, both looking at mother and care provider acceptability, as well as the impact on lactation outcomes and cost. And refinement is underway to create electronic adaptations, language translations, and the use of instruments as a basis for competencies in the care of breast pump dependent moms in the NICU. So I'm excited with this. This was something I've wanted to bring to both the research and the practice field now for about 5 years. It's something we have always standardized in our work at Rush. All of our randomized trials, everything we've ever done has standardized this personal approach, but we've never really put it into an instrument. So I know it's something I've wanted to do for a long time. So I'm excited. I hope you will be. And we'll stop here if there are some questions or some comments.
Wonderful. Thank you, Dr. Meier. We're now going to begin answering questions submitted during the presentation. Please remember you can still submit those questions through the questions pane in your attendee control panel. Our first question, is there information in the pathways of what to do if you suspect someone is moving into an oversupply? Example, getting 5 ounces per pumping on day 3 or at 30 ounces a day on day 6?
I would have to say that is a really interesting question. And there isn't at this point, but I would include that in what I would call the red flags, if you will. So that could be something, if you're working with a mother in particular on that second pumping pathway where it says recommendations, is that whole page at the end, that you would be able to go into that and be able to note for the mother that if this happens, this is something you would want. You know, this is a really good point because I worry when we reach 1,000 milliliters with mothers as well. And I think I'm off on a tangent here, but I think a lot of that coincides with too much pumping too early in mothers that have otherwise healthy babies, and they just want to pump so that they've got extra milk. So, but I agree. I think that would be something you could certainly write in that section.
Wonderful. How could the pumping pathway tool be utilized as a part of a quality improvement process in the hospital to improve the initiation of pumping for pump-dependent mothers? Sorry.
Mm-hmm. So this is where I think that what we've given you, what I think we've given you with the examples of how we're testing it with providers and with mothers. So one of the things, it would depend on what you want to look at. So if you want to look at, does it make a difference for QI, for example, if you're using the two-part instrument, does it make a difference in achievement of coming to volume? That would be what I think is for me would probably be the easiest use clinically. Does it make a difference in pumped milk volume on day 7 or on day 14? And that I think you would do with before and after. So you do before, you get some sense as to what your rates are, and then you implement the pumping pathway, and then you look afterwards. And again, you want to always do QI with a small number of subjects to begin with so that you can test it. But the other thing is you may be interested in, first of all, is it even feasible? Do the mothers like it? So do the mothers use it? Do they want to have it? So that would be a separate thing. You might want to do that first. So say, okay, well, we'd like to put it in QI to see if using it really helps us get to milk volume on day 14. But the first thing we have to do is test it on our mothers and make sure it's going to work okay. I would recommend that as a first step. That might take you, again, 5 mothers. And like in the case at University of Florida, what we found is that every single mother loved this. We were at dinner the night after we tested one of these, and the mother called us on the phone to tell us how much better she felt about pumping after she'd spent the day with us learning about this. So I think that would be my first thing. Test it with your mothers, make sure it's acceptable with them, and then you've got some basis in the beginning about what it was before. Now you put it in, and do you see differences in milk volume? Or do you see, it might just be that you see more pumping. Do you see, you might want to start more simply. Can we get our moms to pump 5 times a day? Can we get them to pump 6 times a day? So I think, again, there are lots of ways, different steps to get to milk volume. It can be, are they pumping more frequently? Because now they understand why. So I think there are a lot of different things you could use it for, but the simplest would be a before and after to get to a certain volume.
Perfect, thank you. I think we have time for 2 more questions. Let's try this one. Maybe it says further in the pathway, one of the slides was asking whether a parent is pumping 5 times a day. Is that your minimum recommendation?
Yes. Okay, so this is really kind of state of the art. Was deciding on what the minimum would be, because our data, as well as the data from several recent papers, and where, if you have your handouts, so when I talked about the pumped milk volume, milk removal studies, there was one our team just published just this summer in 2024, and we spend a great deal of time in that paper discussing the 5 times a day. And so there are good data to show that that's the minimum number of times to be able to achieve coming to volume. Now, if a mother were to pump more, I'm sure we would probably even see more milk. But the 5 times a day is the cutoff as the absolute minimum, because what we see is that less than 5 is not associated with achievement of coming to volume. So that would be the minimum, yes. And that's the beauty of it. You know, you're saying, oh, yes, she's pumping at least 5. But then if you look, how much did she pump in the last, what was her volume in the last 24 hours is the next thing. And then what are your personal recommendations for her? And for that, again, I would even go, when I look at personal, our peer counselors would sit with the mothers and they would say, oh, you know, I think you could get 1 more pumping in here, as opposed to saying, well, you need to pump once more. They would go through and say, well, let's talk about when you're pumping. Oh, do you think when you first come into the NICU to see your baby, can we get 1 extra pumping then, and then 1 right before you leave? So I think that's the kind of personalization I see with this.
Wonderful. And this will be our last question. I appreciate standardizing the teaching and see your QR video links is extremely helpful, but I'm wondering about the text-dense quality of the mother info sheets given the lower literacy level common in our NICU. Did you get any feedback on the handouts from mothers?
You know, this is really interesting because I was thinking I'd like to have 1 more comment about the Provide compendium. So one of the things that really has to happen if you want to use these tools to their most benefit is that you really have to be familiar with the Provide compendium. So whoever's going to provide this care needs to go in and see what's there, not just what the QR codes, what's there. And the QR codes and the Provide compendium is not intended as a handout. So that's number 1. It's not intended as a handout. It's intended for you to sit with that sheet and go through it with the mother, as opposed to handing it out to the mother and saying, here's more information. So what you might be able to say is, you know, this summarizes exactly what we've talked about, which is how I would use it. But the caveat of the Provide compendium for all of the tools is that it's to be a toolkit for the care provider to share with the mother. It's not a handout.
Wonderful. And that's all the time we do have for questions. Thank you everyone for sending those in. And thank you, Dr. Meier, and a warm thank you to everyone for attending today's engaging webinar, My Pumping Pathway, Standardizing a Personalized Approach to Pumping for Practice and Research. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of Medila and Dr. Meier, thank you so much for joining us today and have a great rest of your afternoon. Thank you, Doctor.
Thank you all.